Hey, what's up? Welcome to the Less Invasive Podcast, a podcast covering minimally invasive surgery and assistive technologies for the operating room and radiology environment. I'm your host, Lucien Brodel, co-founder and CTO of Quantum Surgical, a startup commercializing the Ep9 robot for percutaneous tumor ablation. I bring to the table 20 years of experience in imaging and robotics for various specialties, neurosurgery, orthopedics, spine surgery, interventional radiology, and interventional oncology. Today, I'm very happy to have a Professor Yann Nguyen on the show. Yann is an ENT surgeon practicing at Salpêtrière Hospital in Paris, France. He is also a co-director of a research team at the Hearing Institute. He pioneered actually the the use of robotics in ENT surgery with a PhD on cochlear implantation with a robot, and was later on awarded a prize from the National Academy of Medicine for the design he done on the RobOtol device, and we'll talk about that. Professor Yann Nguyen, thank you very much for making time for me today. How are you?
Hi, Lucien. I'm very pleased and very honored to participate to your podcast, and I'm very pleased to have this discussion with you.
Great. So it's two French people that are speaking in English. That's gonna be fun. So
Yeah.
I realized when preparing this episode that I didn't know much about ear surgery. So my background is in neurosurgery, and we designed the RobOtol robot. And actually, this system had a module that we called endoscopy that enabled to maintain and position an endoscope, and it was for transventricular and transnasal approach. So there is some kind of connection to ENT, but more on the sinus surgery when you insert an endoscope through the nose and you do some skull-based surgery. But when I researched the ear surgery, I was just discovering how far I was from understanding this field, the pathologies and the procedures. So we'll talk about that. We'll start with that. But the first question is around yourself. Could you tell us your story into surgery? Why did you choose medical, and why ENT, which is a specific field of surgery?
Well, when I started my medical school, where the general practice for the first 6 years. This is how we do the study in France, and then at the end of the 6 years, we have to choose a specialty. During our first years, we go in medical department, we go in surgical department, and I would enjoy surgery because the day in the operating room goes very fast. You start in the morning at 9, and you end up your surgery at the end of the afternoon, and it's just like the time
Time
goes very
flies.
fast, and you're very pleased. So when you leave the day, or it seems that you had fun all of the day. So that's why I chose surgery. And then I wanted to do a surgery with lots of different kind of gesture. And in ENT, like in urology or gynecology, you can work with a microscope, you can work with an endoscope, you can work with an open field surgery. So there is various kind of surgery, and so there's no routine. And at last, I then had to choose between a subspecialty in ENT, and I wanted to do ear surgery because this field was very fascinating. The fact that you give hearing back to people, the fact that there is many pathologies like tinnitus or vertigos or inner ear pathologies are not very well known.
Mhm.
And I wanted to choose a specialty in which I would be sure that during my whole career, I would progress. I would
Okay.
progress in the surgery, I would progress in disease management, and so on.
Yeah, I mean that's something I discovered looking at all the procedures and the pathologies and the anatomy in ear surgery. That there are a lot of different stuff, and it's very specific, and a lot of different mechanism and stuff to do in the ear surgery. So before we go into that, can you just briefly, for the audience and for myself, just remind what is the basics, of the anatomy of the ear and maybe of the hearing process? How does it work?
So we're gonna couple both anatomy and the
Okay.
physiology. It's gonna be easier for everyone. So when we talk to patients and people, ear surgery is not only the surgery of the pinna. It's mostly surgery of the deeper region of the ear. And when you listen to a sound, it's going to be a wave that will be propagated in the atmosphere, in the ear. It will be collected by the pinna. It will then go through the external auditory canal, so that the tunnel that which you can put your finger in your ear. It will then reach the tympanic membrane. Beyond the tympanic membrane are three ossicles that are connected from the tympanic membrane to the inner ear. The malleus, the incus, and the stapes. They are the smallest bones from the
So
human
how
body.
big is this these bones?
They are very light, a few grams, and the
Oh,
size
okay.
is a few millimeter only.
Okay. Wow.
So they are the smallest bone, obviously. And so the air will vibrate, the tympanic membrane will vibrate, the ossicles will vibrate, and the last ossicles will make the inner ear fluids, liquids from the inner ear, from the cochlea, the auditory organ, vibrate. And in this organ, we have little air cells, so neurosensory air cells with small airs that can vibrate, and they will convert the motion of the liquid into an electric signal that will be propagated through the auditory nerve to the brain, to the central auditory pathways, and you will hear the sound. And this sound will be decoded by the brain, and you will recognize the brain, you will recognize the voice, you will recognize a word, a music, an emotion. So lots of areas of the brain are also connected to these auditory regions.
Yeah, I mean that's fascinating because that's the propagation of sound in the air, in the liquid, and the very little bones and stuff like that. One question about the cochlea. So this is kind of a snail
Snail
shape
shape,
organ.
sure.
What is
Yeah.
it, what's inside that? Why is it a snail shape system?
So you need to imagine that you have to analyze some different frequencies in a
Okay.
very narrow region of the body, because there is the facial nerve and the carotid artery that are going very close. So you need to envelope a kind of tunnel around a distance of at least 30 to 35 millimeter. So that's why it's a snail shape.
Okay.
And if you shout into a tunnel, you will see that the deep frequencies will be propagated further. So
Okay.
in the cochlea, deeper frequencies are analyzed at the apex, at the top of the cochlea, and upper frequencies at the bottom, at the base of the cochlea.
Oh, so that means that all along the circle there are those cells that analyze the sound and then give
Exactly.
the signal
It's
to the brain through the
we
nerve.
call it tonotopy. You can imagine it's like a piano,
Okay.
well, an inverted piano.
Yeah.
Uh,
Yeah, I get it.
Upper
Okay, I
frequencies
get that.
at the bottom, and deeper frequencies at the top.
So
So
now
that's
that I understand the anatomy, what are the main pathologies that you treat, and what kind of procedures do you routinely perform as an ENT surgeon?
so there's basically two parts in the ear. There's a mechanical part, which is the tympanic membrane and the ossicles,
Hmm.
and so we are like a little bit the orthopedics of this
Okay.
region. So when there is a hole in the tympanic membrane, we repair the hole. When the ossicular chain is impaired, we try to fix it or to replace it with a prosthesis. So this aspect of the surgery is pure mechanic. It's biomechanic. On the opposite side, if you go deeper in the cochlea, into the our sensory organs, it's not possible to repair them. So either you amplify the sound with an hearing aid,
Hmm.
common hearing aid that lots of people would wear, and if the cochlea is too, if the air cells are damaged, if the hearing aid will not work, and you will need a cochlear implant to replace the cochlea. So the cochlear implant is a kind of artificial ear. It will convert sound from your environment into an electrical stimuli that will stimulate the auditory nerve directly.
Okay,
So
it's
you
like
have
the
kind of bionic ear, in fact.
it's like a brain stimulator, but for the ear, with an
Exactly,
electrode, a generator, and
exactly.
you have to place it at the right place, and it looks like a very tiny place to go to. Okay, so by definition, we can say that ear surgery is minimally invasive. You never cut things open. You don't dissect tissues much. You're always in a very small area.
Yes, we work in a very narrow area. The workspace is only 1 or 2 centimeter cube, so it's very small, and it's deep also in the body. So it means that we work in a tiny region, in a deep region. So we've got
Mhm.
a lot of problem to move the instrument. We have a problem of exposure of light,
Mhm.
and the last problem is blood, because obviously it's not possible to see clearly with an optical vision through blood, and if you have blood in this region, well, you lost your exposure.
Okay, and just is there any risk with the carrot? You mentioned the carotid artery. Is it a high risk during those procedure, or is it far enough to be okay?
No,
You don't have to worry about that.
the risk is very, very limited.
Okay,
The risk is
okay,
very limited because there is some bony structures around the carotid. So
it's
if you know
protected.
your anatomy and your procedure for a regular surgery, there is no risk of going close or to impair the carotid artery.
An additional question, because a previous episode was about the brain perfusion and fluorescence guided surgery. So, is there a need in this space to look at the blood flow, blood perfusion, see where the flow blood goes? Or I don't hear there is not much around blood in your practice. It's more the bone,
No,
the
no, no.
membrane, stuff like that.
It's not a big issue because the blood vessels that will irrigate the cochlea, they are even deeper, and they
Okay.
are into the bone, and they are too small to be repaired. And the cochlea is very fragile, so it means that as soon as you have a loss or decrease of the blood perfusion, you will lose your air cells, you will lose your hearing definitively. So there's no way we can anticipate or repair this. It's either damage or working.
Okay, and so one of the challenges of surgery, any minimally invasive surgery, is to visualize the critical structures, either the organs at risk or the one you want to repair or to operate on. What kind of visualization do you use during the surgery? Endoscope, microscope, both, intraoperative X-ray imaging. What's the imaging look like?
So the conventional surgery is done with a microscope. We usually use a 20 to 40 magnification amplification. The issue, of course, is the light and the depth of the working field, and the fact that your hand will be placed between the patient and the microscope
Mhm.
in a tunnel. So you will impair your own vision with your hand. This is the reason why some surgeon, but a minority of them, I would say about 5% of them, use endoscope.
Mhm.
And the reason why the endoscopes are so new for ear surgery, even though all the ENTs they use the endoscope for the past 20 years for the nose, so in ear surgery, the reason why the endoscope is pretty new for ear surgery is that we need very small diameters,
Mhm. Okay.
below 3 millimeter, and,
Oh, that's small.
and this is the main limitation of the use of endoscope.
Okay.
And we don't have access to intraoperative imaging in most operating rooms. So this is not something used in routine.
Okay, and so these kind of procedures, do you plan them in advance on CT, MR, I guess CT images, since there are bones and rigid structures? So you do a lot of pre-planning, or is it just you know what you're going to do, and depending on what you see in the microscope images, you do what you have to do?
Well, that's one of the funny part of our surgery. We do a CT scan and an MRI, but CT scan is done in routine. But the accuracy of the CT scan is not always good enough to anticipate what we'll do in surgery. So in
Mm,
many cases, we have to revise our strategy
your plan.
in the
Okay.
operating room and and this breaks the routine. So this is something people like in otology too.
So, like you can every case you discover something that you haven't seen in the pre-op images because you don't have the high resolution to see those very little anatomical structures, right?
Exactly.
Okay,
First
get
of
it.
all, the ossicular chain is very small. It's not always easy to see if the ossicular chain is impaired or not. And there is something that you cannot do on CT scan. You cannot have dynamic images, so you cannot anticipate the motion,
Hmm.
how loose or how fixed is the ossicular chain too.
Okay, so the kind of the range of motion, and so it's a side question. Are you expecting improvement in CT scanners or different kind of imaging to solve that issue, or is it something that you expect to be solved differently?
No, we expect improvement of the machines, of course, but I would expect more on post-treatment of processing of the images rather than the
The
machines
imaging
themselves,
themselves.
because
Okay.
there've been huge improvement on the CT scan accuracy, but even though it cannot solve many of our questions, so I
Okay.
expect more on machine learning to help us in this analysis.
Mm, very interesting. So when it comes to surgery, there is also the outcomes and the performance. So I'm from the neurosurgical ortho space, but in ear surgery, what are the outcomes you are looking for? How you measure your performance? Is it the sound level, some audiometry stuff? What are your indicators to say, okay, I did a good job?
So first of all, there is the otoscopy. We look at the tympanic membrane. If you have a perforation, if you repair a tympanic membrane, you need to check that everything is healed. Otherwise, if you still have a hole, for example, the patient won't be able to swim.
Okay.
He will have infections. So that's the first point. And the second point, which is very, very accurate, is audiometry. So we can test different frequencies, we can test different sound levels. We call it tonal audiometry, and we also do vocal audiometry. So we play a list of words, and the patient has to repeat the words, and we also have a score. So we have very very accurate score. You can compare a technique to another one.
Hmm.
You can compare surgeon results to another one. You can compare prosthesis to another one. So it makes the results very very interesting.
Yeah, I was going to say it's easier to analyze, compare different techniques or the different equipments. When you are based on a pain score that is given by the patient or some like qualitative assessment, it's always difficult, to compare stuff. But if you have a very accurate measurement method to say, okay, this is how we improve the hearing for this patient with those two indicators, that is the foundation of being capable of leveraging any technologies and comparing what is the actual benefits for the patients with a very accurate method. That's very interesting. So, moving on to cochlear implantation, could you explain us roughly the workflow and the equipment? How does it work? Do you insert something in the ear and just you push until the electrode is inside the cochlear? How does it work?
So the cochlear implant has two parts. One is in the external part with a battery, processor, antenna, and it will communicate with a radio signal to the internal part that we'll put during the surgery. And the critical procedure step of the surgery will be the insertion of the electrode into the cochlea. You need to keep as much as possible the residual hearing because some patients still have some hearing even though they need an implant. You need to preserve structure to avoid fibrosis and trauma in order to start rehabilitation with a cochlear implantation in the best conditions. And the surgery is very fast. It's a 1 hour, 1 hour half surgery. Insertion is also very fast. It's like 1 minute or two, but
Okay,
it will affect the surgical
the result.
results for 20 to 30 years because this is the life expectancy of these devices. So that's why we try to put so much effort on these few dozens of seconds that may change or improve the life of the patient for years.
That must be a high level of stress or focus or concentration during just this minute that triggers the outcome of the whole procedure. So yeah, that's very interesting. So moving on to robotics. Now I understand the anatomy, the pathology, and example of a cochlear implantation. And so you were one of the designers of the RobOtol device that is commercialized right now by a French company called Cola Medical, specialized in ENT surgical equipment. And so that was, I understand, a combination with clinical research on your side, technical research from a research lab, and then this company who made it onto a product. Can you briefly explain, because I think the audience may not know what is Robotol, what does robot look like, and what are the components, how does it work?
So first of all, because your audience are expert in robotics, uh, I will tell them that the RobOtol is not a robot.
Oh,
It's a telemanipulated arm.
okay.
So from a scientific point of view, you cannot tell that the device is a robot because it has no autonomy.
Mhm.
Everything is controlled by the surgeon. But because you need to speak to other surgeon, you need to speak to the patient, you need to simplify the words. We tell them it's a robot. So robotol is a contraction between two words: otology, which is the surgery of the ear, and robot.
Okay.
And we wanted to choose a name that would may sound international, because if we would have used a French name, well, it would have been more difficult. And so it's a telemanipulated single arm that will bear either an endoscope to help us for endoscopic surgery, which can be done without a robot, but then you lose one arm because obviously one of your hand is dedicated to the endoscope.
Okay.
Or it can also hold what we call an instrument holder that can bear different tools to grip cochlear implant to insert them, or it can also bear a laser to do some tissue ablation, especially ossicular chain ablation that we do for otosclerosis surgery, for example.
So you do laser ablation. It's just a laser ray beam that
It's a
destroys the
laser
tissue.
beam. We vaporize a bone that is fixed, and we replace it with a prosthesis. And the reason why we use a laser is because we want to avoid as much as possible any motion, mechanical constraint on the ossicular chain, because it's very fragile. And the use of the robot is the way we use the robot is to suppress the tremor, raise our accuracy on one end, and also lower our fatigue. Because when you are doing microsurgery, you need to be very concentrate,
Yeah.
and it's sometimes hard to be concentrated for hours.
Mhm.
And if you want to rest, you need to remove your tools out of the surgical field and bringing them back into the
Yeah.
deafness, into the depth of the surgical field, it's also tiring. So with a robot, you can make a pose. The instruments, they stay steady, close to critical structures, but you can remove your eye of the microscope, you can breathe, and then you can go back a few seconds later and do the difficult gesture. So
So just a
that's
side
one of the
question.
good points.
Yeah,
Mhm.
just a side question. You said you can stop, go grab a coffee, and come back. So the patient is immobilized in some way. Is it a headrest? Is it a strong fixation? How does it work?
Well, most of this surgery is done under general anesthesia. It
Okay.
can be done under local anesthesia in a few cases, but most of it is done under local anesthesia. And the patient is fixed. Yes, you use
Okay.
headband, and it's placed between gels in order to avoid motion. But obviously, some motion cannot be prevented. Sometimes we cut the breathing machine to remove breathing to raise the accuracy and
Okay.
suppress the motions, but heartbeats cannot be suppressed, of course.
Yeah. Yeah.
When
Sure.
we're not going
Okay.
so far.
All right. So it's funny that you mentioned it's not a robot, but because it's a concept that is very similar to the first and most commercialized robot that is right now, the Da Vinci from
Hmm.
Intuitive Surgical. And
Yeah.
for decades, surgical robot means the Da Vinci robot, which is a teleoperated robot that doesn't do anything if you don't move the joysticks, and which is similar to the RobOtol device. So maybe how do you control this robot? So the Da Vinci and other systems, they have a separate console that can be aside from the bed, and so you look at the images. I understand it's a little bit different from the robot, or how you control this one arm.
Well, we have tested lots of different command modes, different of devices in the lab, and at the end, we finally shows what we call a space mouse, which is a mouse that can move in three directions and rotate also in three directions. So you can control six axes of freedoms with such a mouse. It's a cheap device, so it's also important for from an industrial point of view. It
Yeah.
can be replaced very quickly. So this is the reason why we chose such a device to control the robot.
So what you say is basically what you need to do with the micro instrument. The first is to hold it in place in a very accurate way, and then you
Mhm.
do maybe minor movements that are not that complex. I mean, it's not suturing or doing anastomosis. So this 3D mouse that enables those, I guess, the two rotation and two translations, or maybe more than that, is enough
Uh,
for you to control the gesture.
Yes, yes. So 6 degree of freedom, three translation, three rotation, and from a robotic point of view, it's not a position to position a command. It's a velocity command, and we can change the speed of the system.
Okay.
Uh, we can change the speed to adapt
Okay.
to
So
the gestures that we need to do. So we use a faster speed to approach the surgical field, and once we are in the surgical field, we have a normal and a slow speed for very delicate gestures.
So when you're doing your cochlear implantation surgery with the RobOtol, you are sitting close to the patient that is lying on the bed and his head fixed or maintained with the accessories. Then you have your microscope that is
Mhm.
somewhere, and then you have your 3D mouse fixed to
On
the
the side of the table,
okay on
it's
the
fixed on
table
the
rails.
rail,
Okay,
on the
okay,
rail
on
of
the
the
table. So
table.
you have on one end you have the control, and you can manipulate other things when you want to do so. How long is the You mentioned that the implanting the electrode is very short, but how long are you using the robot during a full procedures?
So depending of the procedures, we use the robot for specific part of the procedure or the whole procedure. For endoscopic surgery, we use a robot for the whole procedure
Yeah.
as it bears the endoscope. For the other procedures, laser ablation or or cochlear implant insertion, we only use the robot in a critical part of the surgery. And in fact, the slower we go, the better it is. So when you do a manual insertion, we always tell the surgeon, and everyone knows that you need to go as slow as possible. But it's not
Okay.
possible to have a steady, slow speed manually. So it means that even though the surgeon will tell you, okay, I've inserted a 30 millimeter array in 1 minute, he will do fits and starts. He will stop, resume, but there's no way he can have a steady movement. The robots allow that, and we can go even slower. The slowest speed that we have set on the robot is zero point 0.1 millimeter per second. So I can tell
Wow.
you, you can barely
Yeah.
see anything moving, even under the microscope. So that's why we needed to add a beeping sound, like when a truck is going back, just to tell the surgeon that something is happening, in fact.
Yeah. Yeah. Yeah.
Otherwise, he would believe nothing is happening. Is the robot broken or so? So we needed to add this beeping sound to tell the surgeon, okay, the robot is doing the procedure. The array is being inserted into the cochlea.
Yeah, I mean that's impressive. So just for the audience to understand, our robot is, I think the maximal speed is probably 1,000 more than the speed you just mentioned. So if the robot is going 1,000 times less that what I see, it's probably very slow. Okay, I understand that. So maybe so that's I think I understand the performance of the robot capable of doing this slow and steady motion for implanting the electrode. Maybe accuracy is another performance. What kind of are you looking at some accuracy figures when you do these procedures?
So what we try to improve is to suppress a tremor, to have a slow speed, to really control the tip of the tools to avoid critical structures. We need to avoid contact with the ossicular chain when it's not necessary. We also have the fascial nerve going through the middle ear. And of course, if you damage the fascial nerve, the patient will have a fascial palsy, which is a very critical a critical complication. But what I tell everyone is that today we use a RobOtol to improve our gesture, and we use it to replicate in better what we are doing. But there's many other possibilities with the robotics. You can couple your robot with other sensors. This may be a navigation. This may be some hearing sensors that we have during surgery. This can be a laser vibrometry. This can be fascial nerve monitoring. So there's many ways you can improve your surgery by improving the way the robot and the surgeon will analyze the surgical field. If you give too many information to the surgeon, it won't be concentrated on the surgical field, or it will lose some of the information that you give it to that you give him. The robot is able to receive, analyze, and integrate all these kind of informations that can be added preoperatively or intraoperatively to make your gesture more safer and with a better result. So this is going to be what we're working on today.
So, I mean, that's very interesting. I was not aware of that. So, you said that right now, the robot, or in the future, the robot can be connected to another sensor that provides already information, like you mentioned. I don't know,
Yeah.
it's analyzing of the muscle activity, stuff like that, and this data is provided to the robot, analyzed and displayed on the same screen, I guess, with other information to you, so that you have your cockpit of a airplane cockpit where you have all your information integrated and displayed the way you need to understand where you are going, right?
Well, I would like to avoid the human. I would like to remove the human from this loop. In fact,
Okay.
because if you give this information to the surgeon through sound or visual signal, it will take a lot of time for the surgeon to analyze that, at least a few hundred milliseconds, which is sometimes too much when we do the surgery. So what would be better is to directly couple the robot to the signal, and
Hmm.
at least to stop any motion or progression of
Okay.
the surgery if there is an alert, and then the surgeon can decide to continue or not. But you need some kind of
Okay, I get it.
automation
Yeah.
to make it safer, and but
Okay,
this
so
is
based on the
this raise some
signal, the
ethical
robot would stop. Yeah.
concerns. Yeah, exactly.
Yeah, okay, I understand. I understand. I mean, that makes sense to have at least on the safety part and maybe on functional part other needs, but to stop the robot motion once you get the signal that there's something wrong with on the nerve or the muscle or stuff like that. Okay, so coming back to the robot, the product, can you just explain when it was, when was the first clinical use of the system? I think you did the first surgery with the RobOtol system, and how many systems are out there, and how many procedures? How yeah? What is the today clinical usage of the RobOtol?
So we I well, we will maybe I will very go briefly on the history, but just to tell you, the project started in
Yeah.
2006. We had CE marking in
Okay.
2016, and we did the first procedure in 2018. So when I did the first
Okay.
procedures, it had been already 12 years of work. So even though the first procedure we chose was a very easy procedure, I was very happy. I mean, it was. We went to the OR, and that was a big victory, a big step in the project. So I've been using the robot since February 2018. We were the first center to use the robot. From in the last 4 years, we did around 200 procedure so far in my department. But there
Okay.
are many other departments that started to get the robot, and now we are 15 departments in Europe and one in China who are using the robot. So I don't have the exact numbers of procedures that have been performed,
Yeah,
but
it's just a rough
there
number.
must
Yeah.
be between 800 and 1,000, I would say, today.
Okay. So I think yeah, it's still in a way the beginning of the clinical use of robotics in ear surgery, even though it started the clinical first clinical use in more than 5 years ago. So that's great. So I mean, you've been involved in robotics for ENT ear surgery for a long time. I mean, you've done your PhD on this subject, so I guess you are aware of everything that's happening in this field through the conferences and discussions with other research labs or companies. Right now, there are, I think, more than 150 surgical robots out there, but just a very few dedicated to this specialty, to this space. Could you explain us what are the other kind of systems that exist and how the RobOtol differentiate? I think they do not do exactly the same thing. I mean, even if it's ear surgery or cochlear implantation, I feel they have different way approach to help the physician doing those procedures.
Yes. So there are actually two other robots that have been used in our otological field, and only for cochlear implantation. And no other robots were used for middle ear surgery or even endoscopic surgery of the ear. So one of the robots is called Eero. It's made by Cassination. It has been designed in Bern, in Switzerland, by Professor Caverzaccio. And the goal of this robot is to avoid what we call the mastoidectomy. So when we access to the cochlea, we have to drill the temporal bone. When we do it manually, the drilling has to be quite wide because we need to create space for the light, and we need to create space for the tools to work deep in the temporal bone. This robot, the Eero, is coupled to a navigation system and a facial nerve monitoring system, so it will drill a tunnel without any optical vision. So the accuracy of the drilling will rely
Mm.
on the navigation system, and it will go until the cochlea, but the insertion of the array will be manually done. And this is the main difference with our system. We decided to focus on the array insertion rather than the drilling, because at the time we thought that the mastoidectomy was not a clinical issue. So it may
Okay.
be considered by some people that an aesthetic issue, but it's a rather small it's a small sacrifice for the CI. The other robot that has been used for cochlear implantation that you know very well is the ROSA system. It was obviously not designed for this application, but some surgeon in Amiens, she's called Nathalie Klopp. She collaborated with a neurosurgeon in Amiens, and she decided to use the ROSA to guide the drilling and to perform the insertion of the array with this device too. But there's been a limited number of cases, and the project is on standby so far, from what I know.
Okay, so so basically two other robots that
Yeah,
took a different approach that was helping with the drilling side of the procedure, while you were on the second step that was
exactly.
properly inserting the array into the cochlear. Okay, that's a very interesting. So maybe we clarified the anatomy, the procedure, the robot, how it works, and what how it differentiates with other systems. Maybe we can talk a little bit more about the future. So, first of all, I think there are some navigation system, or maybe there are some navigation. There are some navigation system in endoscopic sinus surgery, skull-based surgery. I'm not sure it can be used this kind of navigation system for the ear surgery. Um, but what do you see? I think you have some research work on right now in the future of the RobOtol system and maybe other stuff. What do you see is missing or should evolve in the way that robotics is done in ear surgery? What's the future for you?
So there's many aspects we can improve. First of all, we are working on a combination coupling of the robot with navigation system. Navigation system of the lateral skull base is not so
Okay,
easy because most of the navigation system use the face for a
um,
surface registration, and
registration. Yeah,
the lateral part of the skull is pretty flat except the pinna. But the
yeah,
problem with
it's
the
not a good
pinna
one.
is that the position of the pinna will
It
change
moves.
between the CT scan and the operating room. So it's not a good landmark. So that's why we usually need
Mhm.
fiducial markers like screws to try to raise our
Yeah.
accuracy on the lateral skull base. So that's one of the part we're working on the robot. The other work we're working on is to give the robot some microforceps, which is not so easy, in fact, because we have some microforceps in otology, but we need to improve them, uh, especially the mechanical aspect, because when you consider a robot-based assistance, you want the forceps to work in the same manner every time, because you want to have the same input in the actuators and motors to open or close the tool. And these micro tools are very hard to shape and build. And actually, there's only a few manufacturers that can guarantee this kind
Mhm.
of accuracy during design. So this is another step we're working on. And the last step we're working on is how we will try to inject drugs or even genetic therapies into the inner ear. So this is going to be the next
Mhm.
revolution in our field, how we can improve hearing through gene therapy instead of cochlear implantation for people who have genetic disease of the ear. So
That's fascinating. I was discussing with another company based in Montpellier who is doing immunotherapy for cancer treatment, but I didn't know there was this kind of gene therapy for the ear that would basically repair, restore the those cells that help with the hearing process, right?
exactly, that's what we hope. Some
Okay.
children and some people that just lack one protein, if we can improve the function or give them back this protein, we may restore the hearing. So in a world change, there is just a small gap, and if you can just fill the gap, maybe we can have some excellent results. But we don't know. It's good. I mean, it's the future. We have to test.
Yeah,
It's
I mean
working
that.
in animal
Yeah.
models. We have excellent results, but we are not in clinical trial yet.
Okay, I mean, those are the three directions. At least I understand. The one is coupling with navigation, obviously, to get the benefit of the diagnostic and pre-op imaging and have all this connected to the robot. The second one is having those micro forceps, which is a challenge on the mechanical design and manufacturability, but that will enable you to do more things with the robot. And the last one, which is something that a lot of people are trying to do, is locally injecting drugs or therapies that will cure the disease. That's great. So, last question about that: do you think, like in the next 5, 10, 15 years, every ENT department will have a robot? Will need to have a robot?
I think so. I hope so, because the surgery is very delicate, so we benefit a lot from robot. The learning curve is long. We use microscope, endoscope. It's There's clearly a benefit of robotization in our field, and I would say that we're a bit behind, considering a lot of specialties in our field. So we need to catch up for sure.
Okay, all right. So you mentioned yourself that doing this microsurgery is can be very stressful. I mean, you have to be very focused, and I guess you are tired at the end of the day if you've done a couple of those kind of procedures. What do you do outside of work to just keep a balanced mind and decompress from a busy surgery day?
Well, I'm doing what lot of people are doing. I'm just running. So I live like 15 kilometers from my hospital, and I like once or twice a week to go home by just running. It's very pleasant. Either the morning or after a long day of surgery, just to run along the road and empty and free your mind at the end of the day.
Great, thank you for sharing that with us. Now is the end of our interview, but I give you the opportunity to ask myself a question, and you can ask whatever you want.
Sure, sure. Thank you. Thank you, Lucien. I would like to thank you for this interview. And my question would be, you've been working also on robotic system with a very high accuracy to pinpoint some structure in the body. Did you consider aiming for the head with your device that you have developed so far? Because from what I know, you're targeting the lungs, you're targeting the liver, you're targeting the kidney, but you're not targeting the head so far. Is this in your plan? Is this in your project to to go for the head?
Yeah, I mean that's a good question. So, first of all, a bit of the story. We sold the previous experience that was the medtech company with the Rosa robot to Zimmer Biomet, and so when we created this new venture, obviously we signed a non-competitive agreement, so to not just redevelop another version of the Rosa for the cranial neurosurgery. So that was at the beginning of the quantum surgical story. But we choose a specialty that is interventional oncology and a specific procedure that is percutaneous ablation. And so we want to focus on that right now. And these kind of procedures that are done in the abdomen, so the kidney, the liver, also in the lung and the bones, so to treat and ablate percutaneously the tumors. And there are also some procedure on the breast and prostate, of course, but it's a different setup for this kind of procedure. So right now we know this kind of technology. It helps to pre-plan on medical images. It helps to position a needle guide or an instrument holder or endoscope maybe, and then to confirm the treatment or the procedure, the effectiveness on medical images by merging the pre and post-op images. So the background of the technology could be applied to a lot of things, but we choose to focus on interventional oncology, and we think there are a lot of things to do in the space we are on. We are working on extending the procedure right now to lung and then later to bone, and it's already a lot of stuff to learn and
Yeah,
to
sure.
adapt the
I
technology
imagine.
to make really a product that is good for the physicians. But who knows? We don't know.
Who knows? I mean, a needle in a way is not very far from a cochlear implant. So maybe one day we will merge our fields.
Yeah, I mean, we'll see. That will be another story. So, thank you very much, Professor Nguyen, for being on the show and sharing everything around ear surgery.
Thanks a lot, Lucien, for your invitation. I was very pleased to participate and discuss with you with this great opportunity.
Thank you. Hang on a minute. We'll chat offline. And thank you everyone for listening